to read about a great doyen in the field of orthopedic surgery, a person no less than Dr. Karam Singh Greval. Dr. Karam Singh Greval was not only a doyen of orthopedics in Punjab, but in the country and on the globe. He was born on February 4th, 1908 at a village known as Rai Singh Wala in an erstwhile princely state of Patiala. He passed his MBBS in King Edward Medical College, Lahore in 1933. He stood first in all the subjects in his MBBS. He was awarded gold medal for being the best graduate, joined state medical services and worked at very highly sensitive places, including ISA Khail, where he repulsed the attack on the hospital by Kabilis. Dr. Karam Singh Greval joined Medical College Amritsar as lecturer in anatomy and passed his MS in 1945. Selected for higher training in orthopedic under the Colombo Plan. He worked in Royal National Orthopedic Hospital, London from 1947 to 49 with a Jackson Borough Award. On return from England, he started orthopedic department in Medical College and Vijay Hospital, Amritsar, the first one in North India. Privileged. Professor, he became professor as early as 1958. His main interests in orthopedic surgery were congenital talipes equinovarus, which most of you know very well. He designed to split tibialis anterior transfer and relapsed clubfoot. Pioneer work in experimental production of Volkmann's ischemic contracture in monkeys to study its etiology, which became a clinical practice later on. Surgery in poliomyelitis, he was very keen, including cerebral palsy, and in bone tumors, and he was also interested in fractures of the femoral neck. One of the main architects of Indian Orthopedic Association, house at Amritsar in 1955. That was the place it is claimed that the IOA started from, Amritsar, under his chair. Trained orthopedic surgeons who later on headed orthopedic department in various countries, in various states and in India. He presented and published many papers on different subjects of orthopedic surgery. And Professor Tulli also had although I never had the privilege of working with him, but Dr. Tulli, who is giving the oration, he had the privilege of working with him, and I invite Professor Surinder Mohan Tulli to read his oration, eponymous oration on his pet subject, tuberculosis, tuberculosis and tuberculosis.
Friends, it's a rare honor for me to give an eponymous talk, and that too in the name of Professor K.S. Greval, a person who made me interested in orthopedics and a person who initiated me to this beautiful and vast, rewarding discipline. You are all warm-hearted people. I request you to show me more warmth by coming to the front seats which have been lying vacant since morning. Kindly give me more warmth. Osteoarticular tuberculosis is a challenge since the arrival of man on Mother Earth. It has existed with human beings since times immemorial, and it is present even today.
You need it.
It kills 3 million people per year, the highest number by one infectious disease. And 1/5 of the total world population of tuberculosis patients is in India. The Western countries, they diminished the incidence of tuberculosis from this high level to this high level much before the availability of chemotherapy and BCG. And that was a reflection of the effect of nutritional states of the society, because most of tuberculosis centers around cell-mediated immunity. If the cell-mediated immunity is low, one can get tuberculosis. There was a short-lived optimism between 1985 for about 10 years that probably we as human beings will be able to conquer tuberculosis. Unfortunately, that was a short-lived impression. And since 1985, the incidence of tuberculosis is increasing all over the world. Amongst the poor countries of the world, it is endemic. Whereas even in the rich countries, the incidence is increasing. The cause of incidence is there are always pockets of deprivation in the world. So long as there are pockets of deprivation in the world, TB will come, find a good host, persist and transmit. The rich countries are a little afraid of us because there is interglobal migration of people. There are haves and have-nots. All haves will have to interact with have-nots, and then there are chances that we may get tuberculosis from those people which are almost acting as culture media for tuberculosis. I think one of the important things which we must understand is skeletal tuberculosis. Clinically manifest skeletal tuberculosis is only a localized manifestation of a systemic disease. If we could do a generalized survey of every patient of skeletal tuberculosis, you will find that 40% of them have an additional active, though subclinical lesion. Here is an example of a specimen from a museum. One can see tuberculosis of the spine, which is present in so many vertebrae in the vertebral column. Here is another example of that we created an experimentally produced tuberculous lesion in the femur. The injection was made in the femur, but by the time the animals died, they had tuberculosis everywhere in the body. When I entered into orthopedics, every patient of tuberculosis was put in a plaster. It was a plaster spica, shoulder spica, or a plaster bed for a tuberculosis patient, and the aim was to obtain a fused joint. This tendency changed with the availability of anti-TB drugs. When the anti-TB drugs were available, we enjoyed the triumphs and euphoria that probably we are going to conquer this disease. And here are a few examples. Tuberculosis of the hip joint, shown in the X-ray, shows you a destroyed hip joint, destroyed acetabulum, and in the MRI, one can see a collection of the fluids in the hip joint and a suppurating lymph node. Patient was treated by anti-TB drugs by a standard method of treatment which was given the name by functional treatment of osteoarticular tuberculosis. Give rest to the part in the best functional position, put them on anti-TB drugs. As soon as the pain subsides, put them on active assisted exercises of a particular joint, and you can probably heal many of these cases with practically full range of movements of the knee or a hip or a shoulder if you have made the diagnosis at a stage of synovitis. Here is the example of the same patient, say at the time of presentation and 1 year after. This patient was treated by drugs on domiciliary lines and giving rest to the hip joint for some time till the pain subsided. If we look at the tuberculosis of the joints in general, it can be classified as stage of synovitis and different, see this is stage of synovitis, earliest stage. Today we have the facilities. The new generation is fortunate to have the facilities of imaging modalities. We can today diagnose a patient of tuberculosis at this stage. If we can make a diagnosis at this stage, you can heal this patient with standard drugs, functional treatment with full recovery of a joint. However, if a patient comes to you at a late stage, the recovery with full range of movements become less. And if a patient comes to you with a fused joint, After completion of the growth for elbow, hip, one may obtain a fairly mobile joint by doing a biological arthroplasty like axial arthroplasty and also do replacement arthroplasty in major joints once the disease has healed. Let's see a few examples of the efficacy, the triumph and euphoria which we got by treating these patients. Patient treated probably about 40 years ago, early case of tuberculosis of the right hip joint at the time of presentation. 1 year after, 15 years after, see the disease has healed somewhere in 1981. The hip joint shows healed status, but there is a coxa magna. Coxa magna can be present in a patient if the disease has occurred in childhood and the hip joint has remained in a hyperemic state for a few years. And any of the diseases can lead to coxa magna. And the same patient, roughly 40 years after the disease, patient is now developing degenerative early osteoarthrosis. The patient, however, has enjoyed this status. He can squat, he can sit cross-legged, but he has enjoyed a mobile, painless, effective, useful hip joint for about 40 years or 44 years. And now is the time that you can think of a fusion if need be. So this is the euphoria and the triumph which we have been able to get, that if you diagnose them early, treat them well, you can give them a mobile joint which is painless, useful, natural. A few more examples at the time of presentation 1 year after, and there's the same patient, there's another patient, a childhood. So you can see the draining sinuses here, pulmonary tuberculosis, and the patient at the age of about 7 years almost shows you a complete range of movements. Those patients who got a fixed joint, those patients who presented late and got a fixed joint, either by fibrous ankylosis or bony ankylosis or ankylosis in a bad, unacceptable position, could be provided a mobile joint by doing the procedure which has been given the name of Girdleston's axial arthroplasty. Girdleston axial arthroplasty permits you a full range of movement of the hip joints. This whole area gets converted into fibrocartilage. It is never a hyaline cartilage, and the patient would be able to. This is one of the one-time operation which can be found useful by the people working in the rural area. They can squat on the floor, work on the floor, what we call floor activities. A rich society, there are many people who don't require floor activities, but in societies, especially people in rural areas, require to work with floor activities, and this is one operation which permits you almost all floor activities except that the patient has 2 to 3 centimeter of additional shortening, and he may require a support while walking outdoors. If the patient is unstable after the axial arthroplasty, there are two procedures which one can do. One of them is that you do a pelvic support osteotomy, something resembling this. In the lowest picture you can see something resembling this. Just do a pelvic support osteotomy, and if still it is found unstable, you can add to it a supraacetabular shelf. This young girl had to undergo an axial arthroplasty. Look at the number of the scars she has on the lateral side of the thigh. After this procedure, axial arthroplasty, pelvic support osteotomy, and a suprapelvic shelf, the patient is able to stand absolutely square shoulders. She is not showing any sign of a Trendelenburg situation. She can squat on the floor, sit cross-legged. Similarly, in the knee joint. Now, this is the knee joint who had early arthritis, treated by functional treatment, range of motion exercises, no plaster, but non-weight bearing exercises from the very beginning, and one can see that the patient has a useful range 0 to 100 degree without doing any fusion or plaster leading to ankylosis. May fuse major joints only for absolute indications. I think fusion of a major joint today should be considered a serious operation. Let's not fuse hip joints, knee joints and lumbar spine just for trivia. Don't fuse them for trivia, because in the long run they put a lot of disadvantage to the kinematics of the adjacent parts of the body. Here is an example of a patient fused probably by me only. About 50 years ago, a young girl was fused. We fused it in neutral position, but some degree of varus has taken place, and you can see the amount of stress she has. She has a stress on the lower and she has a stress on the ipsilateral knee, contralateral hip joint, and the spine. With minor injury, she gets a fracture of the tibia once, and after some time, she gets a fracture of the femur. These operations should not be considered harmless operations. I think we should be very hesitant to operate on these major joints causing fusion. Today, we have the options to provide a mobile joint, provided you have reached a status of healed status. Today, these joints can be treated by, if not axial arthroplasty, one can treat them by arthroplasty replacement procedures. The provision is that the disease should have remained healed clinically, laboratory, and X-ray or imaging wise. 3 years of healed status, one can consider these patients for replacement arthroplasty. However, whenever such patients are offered replacement arthroplasty, do keep it in mind, you must cover them by anti-TB drugs para-operatively for a few months. We will come to them after some time again. So articular tuberculosis, there are so many operative options available to us. Doubt in diagnosis, operate. Unresponsive to multiple drugs, operate. Recrudescence despite drug therapy. Painful ankylosis in healed status. Ankylosis is painless or painful. Painful ankylosis does need treatment. Painless but unacceptable ankylosis, painless movements in non-functional arc. You want your joint to be in functional arc, then you do osteotomies or other procedure to bring a painless range of movements in non-functional arc to the functional arc. With all this euphoria, if you are observant, we will keep on coming across such patients, refractory patients, patients who don't respond. If you are observant and if you are working in a general hospital, not in 5-star hospitals, in general hospital, that is what my country is. We will have patients who are not responding to what you think is a first-line drug. 5 to 10% of patients don't respond. Recrudescence occurs in 2 to 5% of patients. And this is what we call multi-drug resistant tuberculosis. Today, the definition of multi-drug resistant tuberculosis is resistance to INH and rifampicin. It is a microbiological definition. You must harvest the mycobacterium, then only you can have this designation or diagnosis. Unfortunately, in bone and joint tuberculosis, at least in the northern part of the country, we have not been able to isolate or harvest mycobacteria in more than 20% of specimens. So, in other words, we will have to accept a designation as therapeutically refractory cases. Another class is coming up, XMDR. MDR plus resistance to fluoroquinolones and one injectable drug. This is one of the most terrible things which is coming up as a challenge to all of you. XMDR, do whatever you like, at the end of 5 years, most of them die at this stage in 5 years' time. Why do we get MDR? Why do we get resistant cases? One of the reasons is lowered MCI. Here is an example of lowered MCI, lowered cell-mediated immunity, CMI. Here is an example in front of you. Look at the patient. He developed disseminated tuberculosis because his cell-mediated immunity was compromised. He has an active lesion in the skull, humerus, elbow, spine, ribs, both the knees, histologically proved. Here is another example. Mother of a doctor, rheumatoid disease, you can see her hands on immunosuppressive drugs like methotrexate for more than 2 years. She comes back with discharging sinuses around the elbow. Do keep it in mind, use immunosuppressive drugs very, very carefully in our country. Mycobacterium tuberculosis is practically ubiquitous, present everywhere, floating in the air, and if your cell-mediated immunity low, you can get reactivation or formation of the disease. You can see discharging sinuses around the elbow. Here is the X-ray of the same lady. A biopsy was done which showed that it's tuberculosis. Tuberculosis can mimic anything. That also we have to keep it in mind. Here is an X-ray and MRI of a patient who looks like classical avian. But when we were doing core decompression, it was found that on the right side there is histologically proved tuberculosis. Another example of disseminated tuberculosis, even under under treatment, the patient develops other active sinuses. And we should also keep it in mind that atypical mycobacteria can also produce tuberculosis. Here's an example of a patient picked up by one of my younger colleagues. Funny looking osteomyelitis, not responding to drugs. Ultimately it was found that the patient is HIV positive, and the microbiological examination showed us this is Mycobacterium avium complex. Can we sometime have tuberculosis caused by two mycobacteria? Here is an example, possibly. Young man came with paraplegia, operated. I thought adequate mechanical decompression done. Patient recovered, walked for 1 year. And after 1 year, the patient comes back again with this appearance. Another lesion in the lower part of the spine, disseminated tuberculosis in the brain, multiple tuberculomas, tubercular meningitis, and the patient became paralyzed again. One can see probably tuberculous myelitis has taken place in the contents of the dural tube, probably a patient whose one mycobacterium responded and the other mycobacterium did not respond, probably a case of polymycobacterial disease. Here is an example of recrudescence, 1980 to 1987. One can see that in 1987, the patient came back with a recrudescence. I can see my time is flying, and these are two other cases who came back with a recrudescence. Keep it in mind that the patient is going to survive for 20 to 50 years, maybe 40 to 80 years now. With longevity, many of these patients will come back to you. Our collection is roughly 2 to 5% of these patients who had a healed status once came back to you with reactivation of the disease. This young lady was a girl when she was operated. She stayed with a girdlestone. From a girl, she became a wife and a mother, and 20 years after she comes back with tuberculosis of the sacral joint again. This patient, you can see a calcified psoas sepsis, which is there with the patient for the last about 40 years. Patient comes back again with a reactivation of the disease because the patient became now a diabetic. Implants and tuberculosis. I think I'll skip. Do keep it in mind, implants will perpetuate tuberculosis infection. The surgeon has shown his dexterity, hopefully stabilizing an unstable spine. Is it unstable? And this is the follow-up of the patient. One can see the screws, persisting abscess, draining sinuses coming out of the skin. Both the views are showing you coming out of the skin. Same patient. Another example. Putting an implant in the infected area. The surgeon wanted to stabilize this area. And here is the implant which has led to a pathological dislocation and debonding of the graft, debonding of the implant. I would make a request to the new brave generation. If you have put in the implant, you should also have the capacity to remove it if needed. On the whole, if you look at it, about 2% of implants required to be removed for one reason or the other. The implants placed in front of the vertebral column are not removable easily unless you get a DOT permission. Even the primary surgeon will not remove these grafts. Unfortunately, the patient remained paralyzed. You can see the scar through which we went, or scar through which we as orthopedician surgeon went, persisting sinus more than 6 years after, patient in an indwelling and on a wheelchair. Persistent chronic ulcer in a case of Knee joint replacement, limitation of diagnosis. I think I'll go to the last picture, that these are the challenges for the future generation, the future bright, brave, new generation of orthopedic surgeon will face all of them. MRI picture, though sensitive, are not specific in 10 to 15% of patients. Lesions with clinical and imaging diagnosis of tuberculosis, histology comes only as tuberculosis only in 30% of patients. In 70%, the reports are as inflammatory appearance, which means that in these patients, you will have to observe your clinical acumen and write it down on the paper that you have tried everything, so I am starting the drugs on clinical basis. Mycobacteria can be harvested in less than 20% of pathological specimen. Resistant to first-line drugs is emerging at about 8 to 10% of patients. Having achieved a healed status, follow-up of more than 20 years will show you recrudescence to 2 to 5%. At best, we can use a status of lasting healed status. I don't think we have any right to use the word cure stage of the disease. Do kindly keep it in mind, mycobacteria still persist in the human body in macrophages, in cells, in the tissues of the body. They are only waiting to start replication if your cell-mediated immunity comes down. I am thankful to my teachers who taught me. Professor Greval for initiation, Professor Sankran for operative techniques, Professor Durasamy, who taught me orthopedic biology and philosophy. And he was the person who taught me anything, Tulli, anything can be better than what we are doing today. I plead to the new generation, the new bright and brave orthopedicians, let us face the challenges in our country and try to find solutions. Thank you, sir. Thank you.
Thank you, Professor Tulli. Since it's an eponymous lecture, there are no questions on this. And thank you very much for your patient hearing. And now I think it's a valedictory function. Professor Kapoor. So what are we supposed to do now?